So basically, you know, all this confusion about the alignment, but I follow the mechanical, and I go tibia 90 degree to anatomical, and mechanical is same for the tibia. And you can see varus is the most common deformity. Everybody should know these basics, and I'm just talking about the basics of varus deformity. One important thing, it is not only the bone or only the soft tissue. Both has complementary effect for surgery, and you should know both the things correctly. It is not mainly bony, or both are complementary to each other, and you should understand the anatomy and tight structures and severe. So MCL, semimembranous, these are the tight structures, face answerness, posterior-medial capsule, PCL. And one very important is the popliteus. Whenever there is adductor thrust, many times you may need to release and elongate popliteus. That is actually a very important point whenever there is adductor thrust. And medial, sometimes severe medial gastrocnemius. And as you know, everybody, this is a basic thing, flexion extension gap. But one more thing we should not forget, that if there is a joint line change, it can give rise to mid flexion instability. So it's not only the flexion extension gap, but joint line is also to be restored. That is important. So right from basic thing, first thing is after exposure, you go and remove all the osteophytes, and you have to be very careful and carefully remove the osteophyte, preventing any damage to MCL, and it gives a significant release. And as you know, the basic, the tibia gives both flexion extension, contributes for flexion extension gap. Femur, the distal is only extension gap, and posterior is flexion gap. So normally we go for the extension gap first, and there is little adjustability with the rotation. I'll come to that. So these are all basic things. So first thing, you expose the tibia in front and see that mechanical axis anatomically safe, and cut right angle to this. Sometimes the whole time when you don't use a slotted jig, sometimes there's a chance of going to varus if you divert osteo in external rotation or like this. So once you do cutting, if you once you check extension gap, then comes very important is the rotation, selection of rotation. Now, one very important point which is not very well described, and 8% of severe varus deformity, you can see on the medial femoral condyle, there is some new bone formation. So this is something very interesting. 8% of severe varus, they have extra bone. So when you put your jig, because there is only one parameter you put along the posterior condyle, so it tends to go into slight internal rotation. This is a very interesting but very important, and it can misguide you. So remember, whenever there is a, you must see all the other parameters like white side line, intercondyle, interepicondyle line, and also you can check the Ranawat's method, which is a parallel to tibia. So everything should be considered together to fix your rotational alignment, and just take care of this. You may get some cases where there's extra bone, and even with 3 degree you may land up with some internal rotation. So sometimes if the tibia is cut in varus, and if you check with the extension flexion gap with the block technique, you may develop internal rotation, cut the tibia femur in it, internal rotation. So you have to be careful. And before cutting, you always check the gap. Of course, when you are not using robo and navigation, so mechanical, most of the people use the, so always check the gap before you cut the bone, and not the other way. And patella, as you know, when it is everted, actually the lateral part is the medial part, and should not make any error. And so one very interesting thing, we get lot of varus X-ray. So when you take a standing X-ray, you always check for there's an opening on the lateral side. So there's a laxity. Roughly, if I if I say it is a 2 millimeter, so you must cut tibia only if you are planning to put 10 millimeter spacer, cut tibia only 8 millimeter and compensate that 2 millimeter and release only release the medial side 10 millimeter so that the medial both the collaterals are 10 millimeter in length because 8 cut tibia plus 2 of laxity on the lateral side and you release 10 millimeter on the medial side. If you cut 10 millimeter, you have to add 10 plus 2, so you have to medially release 12 millimeter. So this is a very simple thing and standard thing. So always check for this laxity and don't cut more tibia, cut less tibia depending on what is your approximate millimeter of that. Now, one more thing is anatomical tibia. If you see the cut surface, lateral side is small, medial is big, and many times we use non-anatomical tibia, symmetrical tibia, and as Dr. Ranawat has shown, the external rotation is best by you align laterally, that is the size which gives the best size for the tibia, and it should be touching the anterior medial part. So this gives the anatomical best natural rotation, external rotation. And you have an extra bone here in varus, and that can be excised, which releases the superficial MCL. So this is called adduction reduction osteotomy, and there's a sclerotic bone, so there's no possibility of subsidence, and selected TKR size can be further reduced to get extra release of the bone and extra reduction osteotomy. It reduces the medial tibial defect also, and osteotomy technique is very, you have to be very careful to preserve damage to MCL while cutting the bone. So this is typical example of reduction osteotomy. There is so much of extra bone, and when you cut that carefully, preserving MCL, you do get very good relaxation of MCL, which is a very important in severe deformities. And I must compliment Dr. Arun Mullaji. He has a wonderful publication on 173 knees, more than 20-degree varus, and he has also described this technique. Excellent technique. I use it very oftenly. And sometimes you need to release space and again resuture it. And when you do a trial, the patella tracking gives the best complement to say that your component alignment is very good on flexion 90 degree. No thumb test. Central patella tracking is a very good indicator on trial that your implant is very good. And always confirm on the trial and check all the balance so that you have some small way to adjust. And this is a severe deformity. Everything can be done with the manual, and in some patient you do get flexion if you arrange everything, not every patient. So tibiofemoral osteotomy excision, in conclusion, reduction osteotomy, subperiosteal release as and when you require should be the third step. You have to be very careful subperiosteally, and sometimes you may have to release space. I'm little against pie crusting of the MCL and medial epicondylar osteotomy, my personal listing, because it has got a more risk. Most of the severe deformities can be handled with above these four methods. Pie crusting, you are actually cutting the number of fibers of the collagen tissue, which is not good. Coming to flexion deformity, as you know, these are the tight structures: posterior capsule, hamstring, posterior osteophytes, femur, tibia, loose bodies. Quadricep is lax whenever there's a flexion deformity. So don't worry about releasing quadriceps. It is always lax in flexion deformity. So correction, you start with the posterior capsule, circumferentially femur and tibia, remove all the osteophytes, loose body, semimembranosis, PCL. I'm a PCL substituting person, so I prefer the definitely the results are much better, easier, and
Excuse me, Pradeep, we're
very
just running
rarely
short of time.
you need to do
Yeah.
extra distal femoral cut, maximum up to 4 millimeter, but that changes joint line. You have to be careful about that, and always avoid flexion instability. See that extension gap is tight, and you try to uh, adjust the flexion gap. Usually it is lax, so it is very important titration. So femoral osteotomy, osteophyte loose body femoral, and this is how you should release the posterior capsule very carefully from the femur, and it really helps. Go very carefully and around the tibia, that gives wonderful relaxation. Up to 2 to 4 millimeter extra distal femoral resection may be tolerated. Excess distal cut may compromise collateral attachment. You have to be careful and avoid for the flexion instability, but it causes joint line elevation. So first step is to achieve extension gap. Flexion gap is very easy, loose. You have to be very careful. Uh, so joint line elevation can occur if you change the joint line, if uh, if you proximalize the femoral cut, distal cut.
Sir, requesting to summarize, please.
Now to avoid that, sometimes you can do little extra tibial cut and upsize the femur. Posterior bone graft or metal wedges can be used, or sometimes constrained. So this can save extra cutting of the femur. Posterior splint is very useful in most of the rheumatoid patients. You leave some flexion deformity, and this splint really progressively stretches the posterior structures and very helpful. So rheumatoid, some flexion can be kept, while OA, see that you don't leave any flexion deformity. You must have a
A
100%
lot
correction,
more time is remaining,
and
Pradeep.
uh, brace should be maintained in flexion deformity, because always there's a good chance of recurrence. Flexion deformity recurs very fast. So till the tissues are matured, you must maintain the night splint, flexion deformity, correction splints, and encourage active diamond. And these are the severe deformities can be easily corrected. And this is a very uh, museum case, 90-degree flexion deformity rheumatoid and bony fuse. After 11 years she is walking, and bilateral, whenever there is a mismatch you need a constraint, and we use a rotating hinge, and she's got 8-year good follow-up. So conclusion, pre-op correction in flexion deformity useful in some rheumatoid. RA residual up to 40-degree correction can be progressively improved with the splint. In OA, you need 100% correction when there is a flexion deformity. Post-op correction maintained by Pushni splint may require for a long time. Quadriceps lag improves over a period of some time. And dissect carefully. Bones are very soft in rheumatoid than the soft tissues. Thank you very much.